the OPAL seminar. This is our center for optimizing and personalizing treatments for people with schizophrenia. It's an NIMH center, so some of you from SMS might not be aware of that. But today we're pleased to have Joel Braslow speaking about psychosis, meaning and social context, psychiatric care and treatment in state hospitals from 1950 to 1980. I'm not going to read the whole thing that was in the email, but Joel is a psychiatrist at UCLA, and he also has a PhD in the history of science. And he's a historian. He's written a book called Mental Ills and Bodily Cures, and he's currently working on a history of antipsychotic drugs. I've known Joel for a long time now, been reading his work with great interest, and look forward to hearing him speak today. So welcome, Joel.
Great, thanks. Let's see, let's see if I can share the screen, right? Let me do that first. Is that working? Great.
Yeah, looks good. Great.
Well, thanks so much for giving me a chance to talk. So as you can see from the title, I'm talking about the ways in which psychiatrists made sense of their psychotic patients between 1950 and 1980. And I chose those dates actually for a reason. I mean, 1950 is the year that the French pharmaceutical company, Ronflanc, synthesized chlorpromazine, which they later marketed as Thorazine, or SmithKline French marketed as Thorazine beginning in 1954. And as most of you probably know, that it was the first effective antipsychotic drug, and it sparked an unprecedented psychopharmacologic and basic neuroscience revolution that continues to this day. And I chose 1980 as the endpoint. It's the year that the APA published the Diagnostic and Statistical Manual, the third edition. And that was a watershed moment, as you know, and it put an exclamation mark on the decade or so long eclipse of psychoanalysis, and also the rise of a biologically oriented psychiatry. So today what I want to do is look at the ways in which everyday clinical psychiatric practices underwent a radical transformation over this period of time, in the ways in which psychiatrists understood, treated, and cared for their patients with psychotic disorders in state hospitals. And I'll use primarily California State Hospital, both quantitative data as well as patient case files. So my talk is divided in two parts. Part one, I look at the ways in which state hospital psychiatrists made sense of their psychotic patients and the ways in which they attributed psychological and psychodynamic meaning to their patients' psychotic signs and symptoms. And then in part two, which roughly covers some near the end of the 1960s to 1980, I look at the dramatic changes that took place in clinical care state hospital patients and the ways in which these changes transformed how psychiatrists understood and treated as well as cared for their patients. I want to make just a couple points from the outset that are not major themes of the talk, but are kind of underneath the talk somehow in part. And just that these are, I just wanted to point to a number of myths that are commonly held about the history of psychiatry of the last 70 years or so. And they're largely, I think, non-evidence-based beliefs about a number of issues. One is the nearly unquestioned conviction that the care and treatment in state hospitals were the antithesis of humane patient-centered care, and that biological reductionism in the clinical care is a product of scientific and therapeutic advances, and that psychotropic drugs, and especially antipsychotic drugs, were responsible for deinstitutionalization and a narrowing focus on signs and symptoms. So hopefully by the end of my talk, that at least will suggest that these beliefs be viewed with a bit of skepticism as we look at the everyday practices of state hospital psychiatrists. I just want to take a little personal note too before I go into the actual story, is that my psychiatry training and my curiosity about why we do what we do in the care and treatment of patients led me to history. I believe, and I still believe, that historical understanding is crucial to making sense of contemporary psychiatric practices. And so today's talk is very much an effort to understand how the past can help inform our current way of caring for those with serious mental illness. As you know, I live in Los Angeles, and we have the largest unhoused homeless population in the country, although New York does have more homeless individuals. And I'm reminded pretty much every day that in our failure to care for those with serious mental illness, given the number of homeless individuals in Los Angeles. And I'm kind of unusual in that I walk to work pretty much every day. And so this is just a map of West Los Angeles, and Westwood, UCLA is somewhere about here. And it's just that this is obviously, a fairly affluent neighborhood. The median value of houses is about $1.4 million. And but Westwood itself is pretty small. It's only 3.6 square miles, and it's bounded to the east, more or less, by Beverly Hills, and then to the northwest by Bel Air, which are some of the most expensive real estate markets in the city. And then Westwood itself has a population of about 47,000 individuals. But nevertheless, geography and demographics haven't deterred homeless individuals from setting up encampments along the streets of Westwood. And just as this walking to work, there are about 5,000 homeless individuals on the west side of Los Angeles. Many of them now are living in Westwood, which is a smaller component of West Los Angeles. And so I walk past numerous individuals who are homeless, and as I walk to work, and many are clearly psychotic. And I also, it's hard not to feel a sense of shame as you try to ignore them as you're walking to work, even though they're desperately psychotic and ill. And then my truck ends, at the Ronald Reagan Medical Center. And I can't help but be struck by the ironies on my walk through one of the wealthiest neighborhoods in the United States, and past all the dozens of homeless individuals, and then ending up at the Ronald Reagan Medical Center, that, as takes its name from the man most publicly identified with the neoliberal social and economic policies that shaped this our failure to sufficiently care for individuals with serious mental illness over the last 50 years. And then finally, the last kind of personal slide is this slide here. And it depicts the increasing privatization of mental health care in public institutions. And this happens to be the UCLA Neuropsychiatric Institute. And what the point here is simply that we started off, we don't take Medicaid patients, and at the Neuropsychiatric Institute. And although we did take a sizable number of indigent patients when the institute opened in 1961, and about 40% of the patients were indigent, but this slide here, which is just from 2006 to 2018, just shows a progressive decline from about as you can see, from 2006 to about 4%, and it hasn't changed much since 2018. And so ultimately, the question that I want to try to answer in this talk is, or at least not answer, but at least shed some light on, is what are the historical circumstances that have allowed psychiatrists such as myself to be able to either ignore or provide inadequate care and treatment for our sickest and most vulnerable patients. So to answer that question, or at least to try to begin to answer that question, I begin with the post-war period. I think my first point is showing that despite the number of lurid exposés on state hospital care, state hospital conditions improved dramatically after World War II. You can see here, and I added New York's budget just for comparison in California. And what you can see, this slide shows the budgets for New York and California between departments of mental health between 1945 and 1963. And you can see that both expenditures increased substantially in terms of both absolute dollar amounts as well as expenditures per resident patient. In New York, expenditures per patient increased 5-fold over this 18-year period, which is quite remarkable. And in California, expenditures increased even more dramatically with a nearly 8-fold increase over the same period of time. And this had real impacts in terms of the care of patients in state hospitals. And they allowed the increased budget allowed states to repair crumbling buildings and build new ones. California, in fact, built 2 new state hospitals after the war. And this slide here shows overcrowding in California state hospitals. And you can see they vanquished overcrowding quite successfully. Overcrowding had plagued state hospitals over the entire course of the 19th and 20th centuries until up through the mid 20th century. And you can see that in 1946, overcrowding was estimated to be about 25%. And by 1963, this was overcrowding no longer existed, and hospitals were approximately 10% below, I think, 10% below capacity. The increased budgets in state hospitals in entering the 1950s provided the scaffolding for a really exuberant and expansive therapeutic mission that encompassed all aspects of a patient's life. The director of the California Department of Mental Hygiene wrote this in 1952. It's a little tautological, but I think it expresses at least a belief that, and in quotes, everything done to, for, or around a mental patient in a California state hospital can be considered as therapy, since therapy is the ultimate purpose of everything done, end quotes. Increased funding allowed nearly a doubling also of staff, for example, of both psychiatrists and nurses and attendants. And so in a 1950, this is an annual report from 1950 introducing therapeutic activities. And let me just read you a few pertinent quotes. So the report begins, the endless detail of psychiatric therapy sometimes obscures the fact that most techniques employed by psychiatrists are basically experiences in helpful living. And then the introduction ends with this quote: the constant aim is for a total effect that will create a, in quote, get well environment from the moment a patient enters the mental hospital until the time he leaves. And what you can see significantly is that the psychiatric and related medical therapies, psychotherapy is listed first among the medical therapies and is given, in fact, the most space. This is cut off, but it's over a page and a half in the actual report. It reads, there is, according to the medical superintendent, an acknowledged need for this type of therapy on both group and individual basis in the effective treatment of mental illness. And then he continues, fundamentally, the purpose of psychotherapy is to assist the patient in gaining insight that will enable him to discover for himself the exact nature of his difficulties, the factors leading to his present attitudes, and the reasons why they should be changed. And just to emphasize that the smallest state hospital was about, had a population of about 3,500, and then the largest state hospital had a population of about 7,000 patients. And so these are still enormous institutions. And then this is the list of the traditional therapies, both ranging from lobotomy to bibliotherapy. And I had this one also because I like the photograph, but also because it's obviously not the most important therapy, but I think it evokes a sense that nearly any activity in state hospitals could be considered therapeutic. I do think that this actually had effects on outcomes in some tangible ways. And this is a slide looking at release rates of individuals admitted to California state hospitals with schizophrenia, and looking at cohorts admitted in 1949, 1950, 51, and looking at their release rates over a 12-month period. And what you can see is that, for example, in 1949, there were 988 patients admitted to California state hospitals with a diagnosis of schizophrenia, and 63% were discharged within 12 months. In 1956, the last period that I'm looking at here, 79% of 1,500 patients admitted with a diagnosis of schizophrenia were discharged within 12 months. So I'd like to now do is look at how this, what was the actual impact on how psychiatrists described their patients and treated their patients in everyday kind of clinical situations. I'm going to begin with Albert Braslow, and these are I've changed the names obviously, and de-identified the patients in terms of fundamental, so they can't be identified. But Albert Braslow had already had a relatively brief stint at Stockton State Hospital, which is the state's oldest hospital, and it's in the middle of the state, in the fall of 1959, and just after his 21st birthday. And he again became psychotic. Still living at home, Albert had become increasingly, in quotes, aggressive and belligerent when his parents expressed skepticism over his plans to travel to the moon. Despite his anger, they cajoled him into their car, drove him to the local county hospital. There, the examining physician diagnosed a psychotic disorder and transferred him to Stockton State Hospital. The Stockton psychiatrist made a similar assessment, noting Albert was delusional, agitated, and spoke in disjointed as well as fragmented sentences. Albert was diagnosed by the admitting psychiatrist as having a schizophrenic reaction. And here, the psychiatrist probed Albert's past and present relationships with his mother and father as a critical precondition to understanding Albert's psychosis, and based on this, how to best treat Albert. So this is a progress note written shortly after his admission, and the note reads, "In his family, the father appears to be very rigidly and aggressively domineering, and the mother appears to be warm and loving, but an ineffectual parent. There appears to be a great deal of conscious and unconscious hostility between the parents. Shortly after the patient's older sister eloped, an action which the father firmly disapproved, and after the patient's own failure to make an athletic team at school, his behavior became erratic, hyperactive, and less well organized in general. It seems possible that the patient is torn between the desire to act out his father's hostility and the desire to be more passive or submissive like his mother." And so the psychiatrist saw that this conflict had threaded its way throughout Albert's life, becoming, at least according to the psychiatrist, the pathogenic nidus that eventually led to Albert's schizophrenic reaction. The psychiatrist's treatment recommendations reflected his analysis of Albert's troubles, namely to make conscious his largely unconscious conflicts revolving around his relationships with his parents and the meanings these had for him. This would be possible through psychotherapy. The psychiatrist saw no conflict between his psychodynamic understanding of Albert and the prescription of antipsychotic drugs. In fact, immediately upon Albert's admission, the psychiatrist ordered stelazine. The psychiatrist prescribed the drug to sufficiently calm Albert so he could engage in psychotherapy. And then the psychiatrist wrote in one of the notes, "It is my impression that the patient is hungry for a relationship with a male in order to work through some of his difficulties he has with his father." And then in preparing for his discharge, the psychiatrist worried that, in quotes, the dominant father may object if he sees that the therapy is arousing the patient to rebel from this influence, unquote. And the doctors saw stelazine as offering a solution. The doctor reasoned that if he continued to prescribe the medication for Albert, the father might not object to Albert's psychotherapy, and then wrote, in quotes, "The prescription of stelazine, 5 milligrams BID, might serve as an incentive for cooperation of the family in having the patient continue coming to therapy." And to show you that this is a fairly, this is kind of a consistent way of seeing the use of antipsychotic drugs in the late 1950s. This is a 1959 advertisement for the antipsychotic drug Sparing. And it tells a really kind of almost identical story to that of Albert. Like Albert, the faux patient here is, in quotes, acutely agitated, destructive, assaultive, and then the ad copy reads, "Sparing quickly controls acute psychotic episodes, then maintains control while definitive psychiatric treatment is provided." And although in an optimistic time course, the ad shows, in the end, a well-dressed, attentive young man looking deferentially at presumably his psychiatrist, is on the far right there, both ready for the real treatment, which was psychotherapy. The ad, and then also Albert's treatment, case history, point to a clinical vision in which a single set of signs and symptoms, such as agitation, delusions, hallucinations, even if responsive to a chemical agent, did not define the psychotic illness as exclusively biological in nature. State hospitals, though, also in the 1950s, became increasingly important as a place of refuge and seen this way both by patients and their psychiatrists. And probably the best kind of example is the growing number of individuals coming to the state hospital being voluntarily admitted, which was unheard of prior to within the 19th century, a slow trickle in the beginning of the 20th, and then by the mid-century, just in 1946, at least in California, about 10% of patients voluntarily admitted themselves to California state hospitals. And then 14 years later, this had increased to 40%. Martha McFadden was typical of those individuals who chose hospitalization. Exhausted by caring for her 4 children and helping her husband run their farm, Martha fell into a deep depression, and in the fall of 1955, decided she desperately needed help. And Martha told her admitting psychiatrist, in quotes, "I'm here because I'm morbid and need treatment," end quotes. The physician penned a sympathetic account of this young woman who, she wrote, felt deeply burdened by responsibilities to her children, husband, and their struggling farm. Married at age 16 when she was pregnant with her first child, Margaret had 3 more children in quick succession. By the time of her admission, Martha felt desperate, God's voice telling her that her husband was going out with other women, and an even greater fear, according to the chart, in quotes, patient is really afraid of being pregnant, the last pregnancy having occurred after husband had supposedly been sterilized. Patient was greatly upset by this and now states that she would kill him and herself too before she has another baby, end quotes. Martha had hoped that the hospital would provide her at least temporary shelter from her unrelenting exhaustion. diagnosing her with a schizophrenic reaction, her physician wrote the following progress note. She has felt herself quite burdened, has been limited by her recreational and social activities by living on a farm. She has been feeling quite tired, even falling asleep during the day. She seems to want to deny herself the privilege of some rest from this heavy work at home and seems very anxious in an obsessive sort of way to return to it. Obviously, many of her defenses are obsessive in character. She has accepted the hospitalization as a situation where she can perhaps look at her problems with some distance and is just as extremely anxious about the complicated social setting in which she finds herself. And so we are trying to very carefully orient her. Martha ultimately rejected her physician's efforts to care for her, though reluctantly, her mother and husband agreed to take her home. Elizabeth Tock, the ward physician, consented, though she wasn't very optimistic about the outcome and wrote in the discharge note, this patient appears to be quite unstable at the present time and is apparently a borderline schizophrenic with an acute schizophrenic episode prior to and at the time of admission. Nevertheless, Dr. Tock felt she had little choice and then continued to write. Patient has requested her release from the hospital, and it is doubtful if further hospitalization would be helpful at this time, as the patient was obviously unreceptive. Patient may therefore leave when she wishes to do so. So the same clinical vision that shaped how Dr. Tock took care of Martha also shaped how she took care of Esther Irving, who here in this next example that I want to show that kind of makes a nice contrast between the same physician caring for two quite different clinical situations. In this case, Esther was hospitalized decidedly against her will. She was admitted in 1952, and Esther had first become psychotic while in a jail cell after being arrested for theft. Barely arrested for a day, she began hearing voices, according to the chart, voices of the Lord and Holy Spirits. Esther was also convinced that a spell had been maliciously placed on her, and the police quickly realized she belonged in a psychiatric hospital and not a jail. So she was given a diagnosis of dementia precox by the admitting physician who interviewed her. Esther, though, quickly descended into a psychotic hell, really, as God's voice turned increasingly menacing, and the ward television set began broadcasting intimate secrets about her life. A progress note just a month into her hospitalization read, in quotes, patient is very hyperactive, singing and praying in a loud voice, says she is an angel, God has taken possession of her body, combative, resistive, end quotes. Electroconvulsive treatments fell short of controlling her unpredictable attacks on unsuspecting patients and staff, and she had numerous special incident reports that charted her growing violence. And here's a typical one that describes that Esther's sudden off in unprovoked ambushes of fellow patients. And here's the note reads, in quotes, Esther attacked her, and her being a patient, bit her on the right hand, kicked her twice in the abdomen, started on her chest, and hit her in the right eye. No apparent injury to Esther. And then an hour later, Esther's victim plaintively, according to the note, said, Esther is always so nice to me during the day. I can't understand why she changes so quick. And then over 100, at least 100, electroshock treatments, untold hours in restraint, hundreds of hydrotherapy treatments. Esther continued to be quite unpredictably violent. Her husband's desperation to have Esther return to sanity, no doubt, added to the physician's sense of impotence. And the physician wrote, the husband wrote to the ward physician, Dr. Tock, Esther is all I have in life. I love her to no end, and there is nothing more that I would care for than to see her well physically and mentally. I know that it was beyond my power to know what to do in such a case as hers, but I have always had faith in technical doctors because I feel that they evidently possess a greater ability to do more for people, or else they would remain just a common doctor. And so his faith in Dr. Talk and his colleague to do it's something, even as a last resort, led to kind of a fateful decision for her to undergo lobotomy in 1953, which proved less than successful. A note shortly after her lobotomy read, in quotes, patient was started on EST since lobotomy because she was so combative with patients and unpredictable, has to be watched all the time. A note from July 1954 read, receives hydro, has maintenance with fair results, seems to benefit more from seclusion. And then 9 months later, after 100 electroshock treatments, Esther's physicians started her on Thorazine. And the decision to start on Thorazine, they're really hoping that it would circumvent another lobotomy or a more extensive lobotomy the second time around. And the note reads, took medicine reluctantly at first, but is now taking it readily and seems more relaxed. End quotes. And then 6 weeks later, in prescribing 700 milligrams of Thorazine a day, physicians noted that there's been some improvement. The addition of Thorazine then effectively really quelled Esther's doctor's consideration of a more extensive second lobotomy. And in fact, physicians at all California state hospitals abruptly ceased performing lobotomy once Thorazine became available. Nevertheless, despite the usually large doses, the antipsychotic drug proved only partially successful, and Esther again spiraled back into her unpredictably violent attacks on fellow patients and unsuspecting staff who passed within reach of her fists and feet. And what would become a similar pattern over the next few years, a new antipsychotic drug would be tried, often at heavy doses, with initial success, and then a few months later, Esther would lapse back into another round of unpredictable attacks on anyone she believed had crossed her. This, in turn, would necessitate a try at a new antipsychotic drug, which invariably followed the same cycle of initial success followed by failure. Throughout Esther's hospitalization, Esther's family remained involved in her care. They visited her often and took her home for extended leaves of absence. However, for Esther's physicians, the successful elimination of her psychotic symptoms did not necessarily make her or her family ready for her to permanently leave the hospital. Despite Esther's husband's and mother's pleas, Dr. Talk steadfastly refused to discharge Esther, certain that Esther would tumble back into psychosis if she left the hospital for good. Dr. Talk reminded the family that treatment involved much more than simply taking of a drug. Esther's care and treatment required the entire web of relationships and interventions that the hospital provided. The same clinical vision that shaped the care and treatment of Martha as well as Esther, despite the dramatically different ways that Dr. Talk treated both of them, and Dr. Talk's clinical worldview saw both patients and their diseases as embedded in a social context that was critical to each one's care and treatment. In both cases, the asylum functioned as an asylum, required taking into account a patient's wishes and desires and weighing that against the severity of the patient's illness. When we consider Albert, Martha, and Esther together, we see a clinical vision that saw the social context and subjective meaning of psychosis as inextricably bound to both understanding and treating and caring for their patients. It also was a vision that depended upon a particular constellation of institutional arrangements, which in turn depended upon a larger political economy and set of ideological commitments, and none of which would survive intact beyond the 1960s. And so, part two, what I wanted to show is that at least at first show the ways in which conditions changed quickly and quite dramatically from the mid-1960s onward. And this slide is just showing the decline in resident patient patient, how do I get back? Patient population from, and peaking in 1950 and then five rather, and then declining. And you can see the fairly rapid decline after from the mid 1960s onward. And a number of forces converged. This is true in the mid to late 1960s that created this steep decline. The 1965 passage of Medicaid and Medicare, growing community mental health movement, and an ever worsening fiscal crisis of state governments over the course of the 1960s. And you can see I have LPS stands for the Lantrum and Petrus Short Act, and I just put it there just to show, I mean, that dramatically changed commitment procedures from indefinite commitment procedures to ones that ended up being a model for the rest of the country, actually, in terms of limiting how long one and laying out fairly kind of strict criteria. But anyway, that you can see that it didn't dramatically affect, at least the decline seems fairly consistent both pre and post the implementation of LPS. But in terms of the state hospital budgets, and they occupied about some states, state hospital mental health budget occupied about a quarter of the entire state budget. And so you can imagine that they were kind of ripe for being slashed. And this is California's budget. And you can see a fairly rapid decline in the state hospital budget, which corresponds in fact to Ronald Reagan becoming governor in 1968, his 1968 election, and a fairly steep decline. But what the effect this had on clinical care within state hospitals was fairly dramatic, especially, and one of the kind of, I think, major impacts is the shortening length of stay. And what I'd like to do is now show an example of a patient exemplifying the transformation of how psychiatrists saw their patients with psychotic disorders. And this is patient Jonathan Harrison, had numerous hospitalizations from the late 1960s through the 1970s. And it gives, I think, a new kind of a glimpse, at least, into the changing way in which psychotic illness is seen, and as a consequence of rapidly changing conditions of clinical care. And I'm starting with one of Jonathan's earliest hospitalizations. It lasted just 2 weeks, and it began just right before Christmas, 1969. At the time of his admission, Jonathan lived in a makeshift shelter of discarded lumber and dismembered cardboard boxes that he had constructed after his previous discharge just a couple months earlier. And the admission note, you can see it even is incorporating now the new Welfare and Institutions 5150 code of a 72-hour detention. The note reads, the subject was observed barking at passing motorists in the manner of a dog. He was on all fours. He had been brought to the general hospital, but walked away prior to treatment. He seemed to be attempting to pass himself off as a dog, rubbing against the pole. Subject seems to be suffering from hallucinations of impending tragedy. According to the police, patient is a danger to himself and others. Address of the patient, transient. Jonathan's case file chronicles the waxing and waning of his profoundly psychotic symptoms and his growing alienation from his family and those around him. But unlike the patient histories we encountered previously, Jonathan's psychiatrist does not provide a causal narrative of the events that led to psychosis. Instead, the psychiatrist writes as if Jonathan's disease had autonomously unfolded, unaffected by Jonathan's life history or psychology. We learned nothing of the events leading up to his paranoid delusions, why he believed he was being pursued, or why he had chosen such an odd strategy of evasion. For the psychiatrist, what mattered was that the fact that he was delusional. The content of the delusion was irrelevant, just as were the details of his auditory hallucinations. Jonathan's signs and symptoms only mattered as signifiers of underlying disease rather than mysteries with meaning waiting to be probed and unraveled through psychotherapy. The psychiatrist does give a brief perfunctory catalog of Jonathan's social history. He writes of Jonathan's early childhood in quotes, no significant traumas, and that was the extent of it. He gives equally short shrift to the remainder of his psychosocial development. The psychiatrist does note that Jonathan has no residence, which will become an ever-present problem for Jonathan as he careens over the next few years between the street, and jail, and hospitals. And it's, he would be kind of circling through these cycles of hospitalization and homelessness and incarceration over the next decade. Jonathan's discharge summary illustrates the extent to which the nature of disease treatment and the goals of hospitalization look very different than they did in the patients that I described earlier. This is his discharge summary, and it reads, the patient was placed on substantial amounts of chlorpromazine, 1,600 milligrams, to control his agitation and make him bearable by other patients. He would be up all night rummaging through their lockers and generally behaving in a rather bizarre manner. Thorazine rapidly reduced this. The patient, although still obviously mentally ill, was able to understand that he needed treatment and was allowed to change to voluntary status at 72 hours. And then the note keeps reading, on subsequent occasions, he came in and indicated he wanted to sign out and was informed that we did not feel he was ready. The acute aspects of his illness subsided steadily. However, the chronic degree of illness remained substantially high, and it is obvious that this patient will remain a bizarre, chronically schizophrenic individual with intermittent aggravations leading him to repeated hospitalizations. Attempts to contact the family indicated that he was not welcome with the family in any way. Diagnosis, schizophrenia, chronic undifferentiated type, and then the recommendations are that he be referred to an outpatient mental health clinic and a 14-day supply of medications. So there are several points I'd like to emphasize. First, the psychiatrist's focus on his psychotic symptoms and their response to chlorpromazine illustrates a substantially narrowed perspective where signs and symptoms have lost their unconscious meaning. Second, the large chlorpromazine dose achieved over the course of just a handful of days suggests that the psychiatrist increased the dose as rapidly as possible to hasten Jonathan's discharge. And then third, we see the doctor has articulated a radically diminished horizon for psychiatric treatment in his writing, in the discharge summary. The acute aspects of his illness subsided steadily. However, the chronic degree of illness remained substantially high, and it's obvious that this patient will remain a bizarre, chronically schizophrenic individual with intermittent aggravations leading into repeated hospitalizations. And so I think what this case at least points to is that the very definition of successful treatment has dramatically changed. Jonathan's psychiatrist measured successful treatment based on eliminating a narrow set of drug-responsive signs and symptoms. Despite remaining psychotic, though he is no longer agitated and facing certain homelessness when on discharge, Jonathan was declared to have achieved, in quotes, maximum hospital benefit. This, which I think would have been, which would not have, it would have been unheard of a decade or so earlier in terms of discharging a patient to the street, at least. This assessment rested on a fundamentally new clinical vision where the social world no longer mattered in the clinical calculus of Jonathan's psychiatrist. The escalation of drug dosages as hospital lengths of stay shortened was a widespread phenomenon, and this is just to show you, this is from a random sample of patients, which actually the case records that I've been describing also come from a random sample of about 1,000 individuals who were admitted to California state hospitals. And this is just to show, it's a little messy, but showing a fairly increasingly rapid decline in lengths of stay, especially from the mid 1960s onward, kind of even quite short. And then from the same sample, and this is a little more dramatic though, and you see the just the escalation of antipsychotic drug dosage with patients diagnosed with psychotic disorders between 1955 and 1985. And these are in chlorpromazine units so that we could compare across time periods. And I think as psychiatric beds became increasingly scarce, you can see the length of stays shortened. Psychiatrists continued to escalate antipsychotic doses. This created a self-fulfilling and self-reinforcing cycle, I think, in which the limited signs and symptoms that antipsychotic drugs treated defined psychosis and its medical treatment. Simultaneously, the social and experiential slipped further and further into the background, and we see this especially vividly in patient records. The spectacular success of the neurosciences aided and abetted this shrinking clinical vision and added to the belief that that we were increasingly treating brain illness disease as opposed to in a more comprehensive way as they did in the 1950s and early 1960s. As Jonathan, psychiatrist predicted, Jonathan continued to cycle in and out of the hospital throughout the 1970s. As hospital beds became scarcer, as hospitalizations continued to shorten, narrowing what psychiatrists had meant by the maximal hospital benefit phrase. We see Jonathan increasingly kind of bouncing from homelessness back to hospitalizations, which became increasingly scarce over the course of the decade. He did begin collecting SSI checks though in the mid 1970s, which did allow him to spend a few weeks a month in a single room occupancy hotel. Over the course of the decade, Jonathan's institutional circuit, to use Tim Hopper's term, expanded to include increasingly frequent incarcerations that largely for a variety of misdemeanors. His last hospitalization and I lost track of him. I mean, they're no longer, at least I don't know what happened to him after the late 1970s, but his last recorded admission was 3 days, and again was given a 10-day supply of antipsychotic drug, Mellaril in this case, or thioridazine, and again, the final note read treatment completed, and then in parentheses, improved. Then to conclude, the clinical vision of the late 1960s and 1970s, I think, continue to guide and legitimate contemporary psychiatric practices. Psychiatric disease is simultaneously social, biological, and experiential, but modern clinical psychiatry, I think, has failed to come to terms with this reality in at least in a kind of genuine way. In a kind of effective way. And in so doing, psychiatrists such as myself, even, have been unintentionally played a key role in allowing our sickest patients and most vulnerable patients to cycle in ever greater numbers through homelessness and incarceration. The homeless population in LA County now exceeds 66,000 individuals, I think, in the last homeless count. And the proportion of those, and it's hard to know precisely, but somewhere between 25 to 50% probably have serious mental illness. And then if you add substance abuse, it probably obviously the number gets higher. And then similarly, the number of incarcerated individuals with serious mental illness has skyrocketed. Prior to the mid 1960s, the police acted primarily as a conduit to state hospitals, recognizing psychosis when they saw it, and transferred those to state hospitals who had violated the law by virtue of their psychosis. And today, as we all know, an individual's serious mental illness, and especially true in LA County, is likely to be incarcerated, or probably much more likely to be incarcerated than to be hospitalized. And LA County Jail has now become the largest, reportedly the largest psychiatric institution in the world, housing at any one moment in time about 5,000 severely mentally ill individuals. I think though that this history does offer hope. Psychiatrists of the 1950s and 1960s showed us that psychosis does not preclude attending to a patient's lived experience. For those psychiatrists, understanding their patient's inner psychological world also necessitated attending to their patient's welfare both in and out of the hospital. And I think under such circumstances, psychiatrists simply found it unthinkable to allow their psychotic patients to either fend for themselves on the streets or be subjected to the horrors of incarceration. And I'm not trying to make a case for returning to the past, but I do think we can learn from it. And I think our technologies such as psychotropic drugs need not bind us to, or blind us rather, to both psychological and social suffering that is inherent in the very nature of psychiatric illness. Even if we as psychiatrists cannot make history entirely as they please, I think they can, or we can write a different future that takes into account the social as well as biological nature of the diseases we treat. Thank you.
Thanks, Joel. That was very interesting. You know, so I hear that, you know, clearly there's a big change over this time period, and that sounds like, you know, psychiatrists and antipsychotic drugs sort of aided and abetted the changes here. But it sounds like, you know, as their culture changed, it sounds like there was like a starving of resources that really led to the changes.
Yeah. Yeah, and I think, you know, I mean, I think it's easy to confuse sort of the starving of resources in a way and a kind of what you might consider as an iatrogenic, I mean, that I don't think an iatrogenic effect of the technology, you know, the antipsychotic drugs or psychotropic drugs. I mean, clearly they're effective but what I think, you know, it ends up, I think one could end up turning the star, we get confused between, well, is it, you know, because we're using, you know, our focus on drug symptoms, a fact of the drugs or a fact of the kind of social context in which we're caring for our patients. And it's easy to conflate the two, I think. And I think it's easy then to come up with critiques of whether it's, you know, kind of more biological explanations of psychiatric illness or using, you know, biological interventions as the problem, as opposed to a much larger problem. And so what I'm trying to, I think, say is that we need a more kind of sophisticated way of putting together biology and psychology and the social world in, so that's kind of fundamentally, I think, what the argument would be.
Joel, can I ask a question, or is that?
Yeah.
Yeah, thanks. I mean, in some sense, your experience on your voyage to history kind of reflected mine, because when I got out of college, I ended up working with the New York State Department of Mental Hygiene, trying to figure out what I wanted to do in life, whether I wanted to be a psychologist, behavioralist. I ended up working with a really interesting group of people, Ben Pasamanek and Hilda Knobloch, on a research project with the New York State Department of Mental Hygiene. And while they were very much, very socially active and very socially involved, and they ascribed some of what you described, which is the turning away from social services, not necessarily to a change in medication or to the role of medication, but essentially to the racism of the healthcare system. And they were very, very involved with trying to figure out, they were working in the New York State Department of Mental Hygiene, and their primary focus was why psychiatry had become such a tool for real repression. And they ascribed it to the nature of what had happened to the state hospital system in the intervening years since Pasamanek had written Schizophrenics in the Community, which is one of his books. And he had been a big advocate for deinstitutionalization, but he saw it as a radical act of trying to make sure that the social services around a patient were adequate to keep them in in the community. And his analysis, and it made sense to me, and that's why I left psychiatry, psychology, every field having to do with it, because he really saw it as a public health issue. He saw the issue as basically an issue rooted in the migration of African Americans into the city and the repression that occurred when they were suddenly put in a position of having nothing in the community, being provided nothing in the community, and suddenly coming down with lead poisoning, nutritional problems, and a whole host of social issues that psychiatry never wanted to deal with. And so he was very intent, and that it made an impression on me, that the class and the race-based nature of the social service system, in which white kids continue to go to get psychiatric, psychoanalytic services, and they probably still do on some way. It may not be in psychiatry, but it will be in social work and through social therapies and all the rest of it, while Black kids were funneled into the state health system and the state mental hospital system as basically forms of repression. And so I just wonder whether your focus on the clinical practice really kind of obscures the kind of social transformation that occurred around mental health at that point, as our system became much more, he had no faith in the hospital system. He wanted to get kids out of there. And he also had no faith in psychotherapy as a social reform tool, none at all.
I mean, what I was thinking is I completely agree that there's this kind of aspect of racialization of public mental health care that start occurring, with deinstitutionalization. And I was, that you increasingly in the 1970s, the kind of demographics of who's being caught up, and especially as police become more active in this sort of circuit of between hospitalization, being arrested or ending up in or not so being hospitalized, is that and I'm not. It's an I think it's a really good question. But what I was thinking that what is race within state hospital, within when state hospitals had an obligation to care for everyone who needed care, irrespective of the ability to pay, and that so that as psychiatry becomes increasingly narrowly focused, simply, and I'm not making an argument for psychotherapy necessarily, or as much as trying to, how do we think about psychiatric illness as it's embedded within a social context and a psychological context, and as well as the biological context, I think there's something that's going on that, and I don't have a good way of describing it, but I think what you're saying, I think it's consistent with what you're saying, is that there's as psychiatry, I think, narrows more, it focuses more on the, exclusive use of psychotropic drugs, for example, and less on this more kind of, holistic, or kind of larger way of looking at psychiatric illness, that it's part of that. I think this, there's something that's going on with the shift of social services towards the criminalization of mental illness that gets racialized simultaneously, and that I think and the reason why I'm focusing on, I think, and maybe this isn't quite, in this talk it kind of obscures it, but I do think there's a larger social function or a social kind of aspect to this, that I think you're right, is that as psychiatry becomes increasingly focused in a way away from caring for individuals' social and psychological needs, that the kind of the left hand of the state ends up becoming more involved in, and that it becomes also more involved around race and oppression, like you're saying.
Yeah, I wrote this book called Children, Race, and Power, which is about the Kenneth Clark, who was a psychologist who tried to set up an integrated service in New York City at around this time, between 46 and 60. And his critique of psychoanalysis was scathing. In fact, he lost all the support from his white philanthropic friends because of it. And it was essentially that this had become a tool for real repression of the African American community. So you hit on a sore point. You
No,
know,
what do you feel became a tool? I'm sorry, I didn't quite catch that.
well, that psychoanalysis in his clinic that was being promoted by the white trustees and the psychiatrists was seen as state of the art in the 1950s and early 60s, and that it led to a giant schism between how he understood what mental health represented and what the white middle-class psychiatric community in New York, at least, thought it represented, which was this way of, in some sense, pathologizing Black kids and making them up, rather than seeing the social world in which the racism in which the world they had grown up in, and poverty in which they had grown up in. So, it's again,
Those are great.
such a world around there.
Those are great points. I think in state hospital practice, though, it's not actually, they're using a lot of psychoanalytic terms that have become sort of, fairly prevalent, obviously throughout the 1950s onward. But what I think is happening is that it's forcing people to listen to their psychotic patients and what their experiences are like. And they're putting it within psychoanalytic language, perhaps. But I think, at least, there's this context where you're able to have time with your patient and being able to at least, see them as, kind of more within a social and psychological context than increasingly in the case of like the one example I gave with Jonathan, where the psychology mattered not a lot, if that makes sense. So, I was thinking, it's not so much psychoanalysis as just, providing the context in which listening to the patient's experience had some, valent, it was important to understanding how to care for the individual.
Scott, I'm sure there's other people that have questions.
Sure. Well, we usually wrap up about now, but let's see if we've got one more question. Jeff, did you have one? Anyone else? You're on mute.
I think taking, I have a lot of questions, but I think taking a narrow view about, psychiatry sort of reminds me of the former chair at Yale when antipsychotic drugs were brought in and there was a shift towards neuroscience away from psychoanalytic therapy, saying, for the last 50 years, psychiatry has been brainless. Now for the next 50 years, we're going to be mindless. But looking at it sociologically as a tool of repression, or looking at it as psychiatry's, embracing pharmacology and abandoning a more humanistic approach, it's a little too narrowly focused, because the reality was in the history of mental illness and the attempt to try and provide care, there were really no effective paradigms that would be optimal. Pinnell and Dorothea Dix advocated a humane kind of institutionalized environment to support them. And unfortunately, due to resource limitations and other discriminatory attitudes, they became snake pits. And then psychiatry, by embracing psychoanalysis when it had absolutely zero relevance to serious mental illness, further compounded the problem of lack of institutionalization. And then when antipsychotic drugs arrived and allowed for a new way of thinking about community-based treatment, first there weren't models of care that were validated and adequately resourced and in place. So there was a release of patients by legislators to make to save money and to appear that they were doing something which was beneficial for patients, but it unleashed this social set of social problems with homelessness and lack of adequate community-based care. And even when you did have the development of effective models of care like ACT, for example, they weren't disseminated, and they weren't embraced as standards of care. And as psychosocial treatments, whether it's supported employment, whether it's case management, whether it's psychoeducation, whether it's any of these things, as they were developed, validated, they were never adequately disseminated and resourced in a way that provided an infrastructure or a workforce. So, there's clearly blame to go around for everyone, but I think, maybe prior to antipsychotic drugs, there were some caring institutions like, in Iowa, where the Iowa 500 studies came from. It looked like people there were getting good care. But I found out through doing a genealogical study of my family that I had a great aunt who was in Cleveland State Hospital for most of her life for schizophrenia. And just by a completely bizarre coincidence, when I was in junior high school, we had a field trip to that hospital, and I had no idea she was there. But the conditions were absolutely appalling. So, Ohio couldn't be commended for its system. At any rate, so my point is I think you're contrasting, two eras, but it's really a far more complex process that led to the detriment of embracing one approach versus another. And we still have a ways to go, although I think at least we have tools now.
I totally agree with you. Unfortunately, I'm afraid I might have what I was trying to show, and maybe it didn't come through quite in the talk as I wanted it to. But I mean, the point, because it's not about psychotropic drugs in particular being, sort of the engine of creating the circumstance of a kind of increasing focus simply on, the symptoms that psychotropic drugs treat. And what I was trying to show is in the prior to the 1970s, there was this, psychotropic drugs were easily coexisted with more, psychological, psychosocial ways of understanding patients. And that it's the social context is what's shaping how we see our patients, not the interventions themselves, I guess is what I'm trying to say. I mean, certainly, as a clinician, all my patients are on antipsychotic drugs because I treat people with schizophrenia. And so they're critical to caring for people. I think and certainly as a clinician, just teaching residents, I want to make sure that, that they see their patients in a much larger context. I think is what I'm trying to argue for. It isn't, and that these larger social forces that we don't have, control over necessarily, often shape how we see what counts as a legitimate, sort of the kind of the entirety of what psychiatric treatment is rather than what it ought to be, if that makes sense. So it's really more of an argument trying to say how we need to kind of think about how social context is shaping how we're seeing the world, not that there's anything, the drugs we use are critical to our treatment of patients, obviously. So it's not meant to be I guess it's meant to be a kind of showing the way in which context shapes the way in which we kind of understand illness.
Well, a single case example that may illustrate a point, my point, or some point, is Ellen Sachs, your Los Angelian colleague.
Yeah.
Ellen Sachs had a pretty good outcome despite having severe illness. And why did she? Well, when Ellen was at law school at Yale and really in the throes of illness, she was treated pharmacologically, reasonably well, and then got onto clozapine pretty readily when it became available. But she was in psychoanalysis, so she saw a doctor 5 days a week. Now, it wasn't the analytic therapy that she had. She just had an individual who was committed to her well-being, who was a stable guiding force in her life.
Mm-hmm.
So, there you see sort of the combination of a psychosocial therapeutic approach
Right.
with a pharmacologic approach that yielded a pretty good outcome.
No, absolutely. And to be honest, the patients I see in our clinic all have families who care, that are able to maintain a loving relationship with their, with the person for the most part, that, so that all of our, patients are at least in stable living situations and care for family. And we, the family comes in as often as, the patient, with the patient usually. And Ellen Sachs is a great example of someone who, was able to function really well in spite of having periodic psychotic episodes, because she had, someone who was there for her. I think you're absolutely right. And so I completely, so I want to emphasize this is not about kind of, an effort to, cast particular interventions in a particular way, but the way in which interventions get cast by the social context in which patients find themselves in. And just to give a really short example, that, is that when, we've been often the rationale for allowing police to take a patient from the ER who's committed some crime because of a psychotic illness is, and the ER doctors and psychiatrists actually have felt it was okay to allow someone who's acutely psychotic, who needs hospitalization, to be incarcerated rather than to be hospitalized, with the belief that, just the prescription of the antipsychotic drug is sufficient treatment in the county jail, which often, which is really sort of, the jail is a pretty horrendous place, I guess. So it's not, so.
No beauty shop therapy there.
No beauty shop therapy there. Absolutely not.
Joel, thanks so much. I am gonna, we went way past my
Oh yeah, we
my
did.
deadline, but it was very interesting to hear you speak, your talk, and glad Jeff got to weigh in there too. And thanks so much for doing this for all of us.
Absolutely.
All right.
Bye-bye.
Have a good evening.
You
Bye.
too.
Thanks.